Okay, let's move on to dyskalemia. And I think, we'll get to the algorithm. I think what I'll do is I'll come back to the algorithm. I'll hit it quickly as a high value on a high level. We'll get to the granularity of this as we parse the chapter, the field guide chapter in more detail. How we're approaching it has some intuition. Is it real or not, right? And then if it is real, is it total body K excess or is it a transcellular shift? And then if it's total body K excess, is the kidney responsible or not? And if the kidney is responsible, is there some problem with aldosterone? So that's really the skeleton approach of this hyperkalemia. All right, and then we'll go through various tributaries on this path as we parse the chapter. Okay, what I want to spend time on is something that you're not going to be tested on, but I think you should know, because how much of your daily life is engaged in managing hyperkalemia. To me, I want you to understand the physiology of the effect of hyperkalemia, as well as much as is known. There's plenty of holes, as well as some of the measures that you use, the calcium. Why does calcium even help in hyperkalemia? So we have to talk about the action potential in order to get to there. Okay, so let's talk about the various phases of the action potential. So you'll see on the y-axis is the resting membrane potential. You'll recall that this is established because there is at rest a large amount of K, somewhere around 100 to 120 millimoles of K in the cell, right? And there's fairly low amounts of K outside of the cell, right? And so if I have a pore, a channel, then the egress of K, a cation, from the ICF to ECF will create a negative resting membrane potential. Okay, and so that's the physiology at play with essentially all cells, including the excitatory cells of muscle, as well as the conduction system of the heart. Okay, so you have a resting membrane potential that occurs because of the leak of K from the ICF to the ECF. Okay, now you have a high extracellular sodium concentration, right? Somewhere around 140 in the ICF on the ECF side, right? And about 10 on the ICF side. So there's a tendency for sodium, if I insert a channel, for there to be an influx of sodium into the cell. Okay, so if I have a resting negative potential difference, if I open that channel, sodium rushes in, I then become less negative. So that's the upstroke, the sodium influx. That's when the action potential starts. Okay, and there is a slope to the resting membrane potential in pacemaker tissues, so that you gradually reach so-called threshold. Once you reach that electrical threshold, sodium channels open in those pacemaker cells. Okay, and so again, you have this sodium influx that results in the upstruck to the action potential. Okay, now more K channels open in order to, and sodium channels close in order to shift this downward again. Okay, that's this K efflux. The phase one of the action potential is the loss of more K from the ICF to the ECF. So I'm flipping it back down. And then there's a phase at which calcium channels open. Okay, calcium in the cell is exceedingly low. Calcium goes into the cells. So now I'm making it, I'm reducing the slope, right? I'm making it less aggressive in its decline to negative by calcium rushing in. Okay, those calcium channels close, and then unopposed K flux results in restoration back to baseline. Okay, that's the action potential. Okay, that's what all of this says. okay? Now, let's go over hyperkalemia and hypokalemia. I often start with, maybe unfairly, I often start with, what do you observe? And then sort of rationalize how you get there, because it's totally unintuitive. The way that hyperkalemia does the things it does is not so intuitive. So you got to start on what you observe, and then we can say, okay, let's try and create a fairy tale on how to get there. Okay, so what do we observe with high K? Watch my time here. Right, one of the big things we see is broadening of the QRS, right, and then peaking of the T wave. Right, those are the things that we see: QRS broadening, and then the peaking of the T wave. So how can that make sense? Remember, T wave peaking is, oh, let me take one tangent real quick. I think this is an important point. The ability of dyskalemias to cause electrical instability has much to do with chronicity. Okay, why is that? We have to talk that through real quick, and then we'll get back to the EKG changes. If I have a patient who has Gittleman syndrome, okay, or let's take a CKD patient. Let's start with hyperkalemia. CKD patient eating lots of K, right? Their K goes to, let's say, 6, all right, in the ECF. That's the measurable side. But the intracellular K also goes up some, right? What causes instability, electrical instability, is what happens to the gradient between the ECFK and the ICFK. Anything that dramatically perturbs that gradient will cause more problems, okay, both in terms of symptoms or electrical instability. If I increase the ECF and ICF K content, I will have less effect. That's why when I get a call from CKD clinic in a patient whose K is 6.5, and I go back to the chart and I say, oh yeah, their K is 5.9, 6.1, 6.5. I say, I'll get to this at some point. And sometimes I forget, and I call the next day and say, hey, stop your ACE inhibitor. You don't need to come to the emergency room, or stop eating, mangoes, give them a little education, and then let's do labs in a week. That's how I manage CKD clinic hyperkalemia. And up until recently, I was the medical director of renal clinic, and I'd had to do this all the time. Thankfully, I've handed that off. Sadaf is getting these phone calls now. So all of these hyperkalemias that you're not being called about. So during after hours as the on-call fellow, all these during daylight hours, they came to me. And I think fellows often default. Who's their supervising faculty, even though they didn't staff with me? Sam Bendam. So they all just came to me. So in any case, you don't have to worry. The point I'm trying to say is, if it's chronic hyperkalemia, you don't have to worry as much. Okay. On the flip side, Gittleman's patients. So those Gittleman's patients, they often come off their K supplements, or at least take half as much as they're supposed to. And they're sometimes have to take like 160 millimoles of K a day, ridiculous amounts. They have also depleted the ECF and ICFK. So when I get a Gittleman's call and it's a K of 2.8, right? I'm like, oh, okay, I got to make that, put this in my task list of the day, but I don't need to drop what I'm doing and manage this right now and whisk them off to the ER. I just say, hey, Mr. X, you stopped taking your K, didn't you? Please start taking your K. Let's get labs in a couple of weeks, as long as they're not symptomatic. Okay. The worst case scenario is the hypokalemic or hyperkalemic periodic paralysis, right? In that scenario, in a hypokalemic periodic paralysis, you get a shift of K from the ECF to the ICF, or in the inverse, hyperkalemic periodic paralysis, you go in the opposite direction. So I'm getting a reduction in ECFK and an increase in ICFK. That's the worst case scenario. And that's why, literally, you're paralyzed when you have a K in the 2s in a periodic paralysis, or in the other side, hyperkalemic periodic paralysis. That's the worst case scenario. Okay, everybody get that? All right, we have the principles where we can go back to EKG changes. All right, so again, if there's something happening with repolarization, right? Peaking of T waves, you'll have to sort of think about, well, where are we in the action potential to make this make sense, right? Where repolarization occurs. Remember, repolarization has to do with K efflux, right? That's how you reset back to baseline. So, and then if something is happening in my QRS, something is happening in my sodium channels, the upstroke of the action potential. Okay, so now let's compose our fairy tale, now that we've seen the end that we have to get to. By unclear mechanisms, I get to use that, right? Not because it's just not unclear to me, or just not because it's unclear to me, it's unclear to, the body of medical knowledge, okay? I haven't queried ChatGPT to see if ChatGPT knows this, but, based on my survey of the literature, there's not a clear mechanism here, but it's been documented in even PNAS papers that these phenomenon actually occur, right? When there's an extracellular increase in potassium concentrations, there's a reduction in K efflux K channel conductance, okay? This doesn't make sense, right? Because if I increase my ECFK, if anything, my tendency for K to leave the cell should be less, okay? So the only way that you can make this make sense is that, I said reduced, the K efflux channel, the K conductance increases, okay? So that increases repolarization, right? It makes that T wave peak, right? Because otherwise, again, an increase in ECFK should result in a less favorable gradient for efflux of K, right? So again, there has to be something going on with channel conductance. People have shown that in some basic science channel studies, or patch clamp channel studies, okay? So that increases the slope of repolarization, and that's what you see, the peaking of the T wave, okay? Now, the sodium channels, okay, are also affected by the ECFK channel, the ECFK content, because they are influenced by the resting membrane potential. Okay, so if I have an ECFK that's relatively high, then the egress of K is blunted at rest. Okay, this is not at repolarization, but at rest. And so my sodium channels are affected by that modified resting membrane potential. And the result is a more sort of slurred opening of sodium channels, okay? A prolongation of that upstroke in the action potential, okay? Hence the widening of the QRS, all right? On the flip side, okay, we'll get to calcium administration here shortly. Let's talk about the effect of hypokalemia, okay? So again, what do you see in hypokalemia? Well, I see that there are these U waves, right? I have my QRS, I have my T wave, and then I get these U waves. So why might I get these U waves? Let's, again, compose the fairy tale, okay? So just as ECF potassium affects or increases these potassium channel conductance, low ECFK decreases that potassium channel conductance, okay? So if I get that, then repolarization is delayed, okay? That repolarization is delayed, right? This ability to restore back to baseline is delayed. Remember, though, I have calcium that's coming into the cell. And so that calcium that's coming into the cell with a less vigorous egress of K can result in these after depolarizations, these U waves that show up. Okay, so that is some of why you see those U waves. Okay, the effect of calcium on hyperkalemia seems to affect the threshold for sodium channels to open during phase 0. Okay, and so even though I might have a altered threshold for sodium channels to open in the setting of hyperkalemia, giving them calcium kind of restores that normal threshold for sodium channel opening. Okay, and so hopefully that gives you some insights. I can have you read more into some of the more detailed aspects of these effects of dyskalemia on the action potential and the defensive attributes of calcium in the setting of the mechanisms of defense of calcium in the setting of hyperkalemia. Okay, with that, we'll move over into some of the clinical syndromes of hyperkalemia. Okay, again, reflecting back to where we are on the algorithm, we're going to first ask ourselves, is this real or not? The clinical clues of a hyperkalemia, is that doesn't make sense. Okay, no symptoms, no EKG changes. So this may be a case of pseudo-hyperkalemia. And so examples of syndromes that can cause that are anything that has a very high white cell count. Okay, so CLL being a classic one. Very high platelet count can do the same. Essentially, what you're having is that ex vivo in the tube, you have cells that are releasing their high K content into the ECF in the test tube, right? Prolonged tourniquet time is an example of, remember, even my muscles, which have to allow K to leave the cells in order to repolarize. If I put a tourniquet on that limb, the muscles that are trying to repolarize are going to cause high K content in that limb. Okay. In fact, some of this K that's leaving the cell actually influences blood flow in the limb. Okay. So muscle exertion causes vasodilation in part because of the K that's being lost from the cell, from the myocyte. Okay. But if I have a tourniquet on this limb, this repolarizing muscle cell is going to cause a pseudo hyperkalemia because you're sampling that ECFK that is not being returned back to circulation because of the presence of a tourniquet. Okay, so these are again some of the causes of pseudo hyperkalemia to be aware of. Trauma, where I'm causing hemolysis, would be another one. This fist pumping with a tourniquet on is another. Getting blood cold, especially when you have that hyperleukocytosis, is a phenomenon in which this K leak is accentuated. So one way to get around that is to try and transport the sample to the lab quickly, okay? Or do a point of care test. The point of care tests, obviously are done rather promptly, and so that can mitigate some of this, this pseudo hyperkalemia measurements. Okay. I think we're at the end of the hour. We're at a section where it probably makes sense to stop right there. We'll talk about hyperkalemia due to transcellular shift next time. For now, we'll leave it there. For any questions about the topic of hyperkalemia, the areas that we've covered so far?